everyone, today we'll be discussing the chronic disease chronic obstructive pulmonary disorder, also known as COPD. We will discuss what it is and then later go into detail regarding the physiology and symptoms behind COPD. We will then discuss why it is considered a chronic disease and why it's complex, and then later discuss the epidemiology behind COPD. And lastly, we'll talk about the steps taken in the rehabilitation strategy. So what is COPD? COPD is a lung disease that makes it difficult to breathe. It's a long-term disease that gets worse over time and is characterized by inflammation and limited airflow that goes in and out of our lungs. It's caused by long-term exposure to gas irritants, and smoking is the leading cause of COPD. It's typically involved with chronic bronchitis and emphysema. And once diagnosed, it's hard to reverse.
COPD is characterized by progressive airflow obstruction, which makes breathing difficult. It causes damage to the airways of the lungs, resulting in swollen and blocked airways and loss of elasticity or stretchiness. The airflow obstruction, which is characteristic of COPD, occurs due to the following.
The bronchioles and alveoli lose their shape and elastic quality. The walls between many of the alveoli are damaged, forming fewer, larger alveoli rather than many tiny ones, and this leads to a reduced amount of gas exchange in the lungs. This is also known as emphysema. The walls of the bronchiole become thick and inflamed. The cells in the airways produce more mucus than usual, which clogs the airway. And the last 2 points are also known as chronic bronchitis. Common symptoms of COPD include dyspnea or shortness of breath. This can occur with light exercise. However, it occurs especially with physical activity. Cough with or without sputum production, and wheezing or a whistling sound when breathing. Chest tightness, which is caused by swelling and extra mucus, which leads to narrowing of the airway. Fatigue, especially with physical exertion or doing daily activities. This is due to the lack of oxygen. Severe COPD can result in additional symptoms such as swelling in the legs, feet, or ankles, the lips or fingernails turning blue or gray due to low oxygen levels in the blood, weight loss, and lower muscle endurance. The severity of symptoms depends on how much lung damage one has. It is important to know that COPD is a progressive disease. As the disease progresses, symptoms often become worse.
Chronic disease definition. We'll first define chronic disease. Chronic disease, as defined by the Ministry of Health and Long-Term Care, is a long-term disease that develops slowly over time. Often progressing in severity, it can be controlled but rarely cured, may significantly impair everyday physical and mental functions, and reduce one's ability to perform activities of daily living. As the name implies, COPD is a chronic disease. It is a slow progressive destruction of the airways distinguished by gradual loss of lung function, which is a combination of chronic bronchitis and emphysema. It is characterized by chronic obstruction of airflow to the lungs interfering with normal breathing. An example would be exacerbation, also called COPD attack, which is a sudden worsening of COPD symptoms, which typically lasts for several days. The disease cannot be cured but can be controlled through medication, treatments, and rehabilitation strategies. COPD also causes increased shortness of breath, leading to breathlessness during exertion and at rest, impacting activities of daily living, reducing quality of life.
Complexity can often be described in terms of having more than one disease or comorbidity, healthcare utilization, and psychosocial, environmental, and lifestyle factors. COPD is a complex disease. 80% of individuals with COPD are estimated to have at least one comorbid chronic condition. These conditions include pulmonary artery disease and malnutrition, which are directly caused by COPD, in other words, consequential comorbidity, and others such as anxiety, depression, metabolic syndrome, osteoporosis, obesity, diabetes, sleep disturbance, and anemia, which do not have an evident underlying pathophysiological relationship with COPD. This would be known as cluster comorbidity. These comorbidities have a compounding effect on the individual. They increase illness, they can oftentimes cause death independent of respiratory failure, and they make the management of COPD more difficult. For instance, an individual with secondary pulmonary artery disease must now also manage symptoms associated with the disease and possibly take medications to lower cholesterol in addition to managing their COPD. There is further evidence that these comorbidities have a negative impact on COPD patients in terms of exacerbations and quality of life. Due to these comorbid conditions, an individual may have more frequent visits to the hospital or their healthcare provider and have increased healthcare costs, making COPD even more complex. According to the Canadian Institute for Health Information, COPD accounted for the largest percentage, which was 18.8%, of 30-day readmissions to the emergency department in Ontario. In Canada, acute COPD exacerbations resulted in hospital-based costs of $646 to $736 million a year. You can see that due to the additional burden of increased healthcare utilization and costs, COPD becomes more complex.
Who is at risk? Number 1. Greater than 35 years of age. Individuals 65 years or older compared to an individual aged 35 to 49 years old are more likely to have COPD. Number 2. Chronic smokers. Current smokers are 5 times more likely to have COPD compared to never smokers. Number 3. Socioeconomic status. Lower incomes equals higher odds of increase in COPD. Number 4. Uneducated. COPD is highest among those with low levels of education. Number 5. Overweight/underweight. Obese individuals are 1.58 times more likely to have COPD. Underweight individuals are 1.81 times more likely to have COPD. The line graph just shows the increase in the risk of COPD with age. Incidence. The line chart on the left illustrates the percentage of Canadians aged 12 and older of current smokers and daily smokers from 2001 to 2011 for males and females, while the line chart on the right illustrates COPD incidences per 1,000 for Canadians. The current smoking rate in Canada, 12 and older, was 19.9% in 2011, down from 25.9% in 2001. The rates for men and women both dropped 6 percentage points during this period. Men from 28.1% to 22.3%, and women from 23.8% to 17.5%. The COPD incidences also show a similar decreasing trend in both males and females, showing the relationship between smoking and COPD, as smoking is a driving factor to COPD. Prevalence. This trend increase was seen in the first part of the period, 2001-2004, relative increase of 6.9%. And then showed a plateau in the later part, 2004-2011. Since 2004, a relative decrease of 6.0% in men as well as a relative increase of 5.8% was observed in women. For the overall period, age standardized prevalence was higher in men compared to women, but this increase seems to be borne by women. Due to non-smoking interventions, public health awareness, ads, education in schools help prevent death, but there is no cure to COPD. Thus prevalence are fairly high.
Here is another graph displaying COPD prevalence across Canada. The highest prevalence is in Ontario amongst both sexes compared to other provinces and territories, females being the highest and males being the lowest. So the lowest is in PEI among both sexes compared to other provinces and territories, females being the lowest and males being the highest in PEI. The lowest amongst females is in the Yukon. No male population is available since the data is too unreliable, and no data is available for the Northwest Territories and Nunavut, since also unreliable. The burden of chronic obstructive pulmonary disease across many world regions is high. Based on the best available evidence and publicly accessed scientific databases, there are many COPD prevalence and number of disease cases from 1990 to 2010. So 227.3 million COPD cases in the year 1990 amongst the people aged 30 years or more, a global prevalence of 10.7, and the number of COPD cases increased to 384 million in 2010, with a global prevalence of 11.7. These are the individual increments in prevalence of COPD. So there is the least in Southeast Asia from 7.9 to 9.7. And the highest in Americas, so including North America and South America, is 13.3% to 15.2%. In Europe, the increase was 22.5%. In Africa, being 102% increase. And the Eastern Mediterranean from the 118% increase. The global prevalence of COPD is projected to increase, becoming the third leading cause of death by the year 2020. As of 2012, COPD was the fourth leading cause of mortality in Canada. In 2011, 4.4 of all deaths among Canadians were caused by COPD. This chart provides an overview of the death rates from the COPD between 1950 and 2011 among Canadian men and women 40 years of age and older, and also shows the correlation with smoking and COPD. Among Canadian men, smoking rates have been declining since 1965, while the death rates from COPD began to decline in the 1990s. Smoking rates for women were relatively stable from 1964 to the early 1980s. There's been a consistent decline in the smoking rate. It did not occur before the early 1990s. There has not been yet a decline in COPD death rates among women. However, there has been no significant change since 1997. A possibility for this trend is that women may be more susceptible to COPD than men, particularly smoking-related COPD. Decreases in lung function that occur naturally with age do not differ between the sexes for non-smokers. However, population studies have shown that among current smokers, lung function decreases at a faster rate in women as they are compared to men, even when an adjustment is made for the quantity of cigarettes smoked. This suggests that smoking may have a greater effect on age-related decrease in lung function for females than it does for males.
One of the few disabilities caused by the index disease COPD includes shortness of breath during normal to physical activities like walking or climbing stairs. These disabilities make it quite difficult for an individual to work and move around. These movements are a necessity to maintain the body's overall fitness. Lack of movement, pulmonary insufficiency, and additional entities like arthritis, heart failure, diabetes, stroke aid the disabilities that occur secondary to COPD. Right heart failure being one occurs secondary to COPD due to oxygen not reaching areas of the lungs. Since oxygen molecules can't pass the obstructed airway, the body compensates by making the heart to work hard, resulting in hypertrophy. This causes the blood to back up into veins, resulting in fluid accumulation in organs and tissues. Therefore, we see the swelling of legs, enlarged liver and veins, and so on. This further burdens completion of simple activities as previously mentioned. Other burdens caused by right heart failure is shortness of breath when attempting once again these basic activities. The only time the person is at ease is when he or she is at rest. Lack of activity also leads to non-respiratory disabilities such as loss in balance, muscle endurance, and so on. Since the body muscles are not being utilized as in a normal sedentary or moderately active person, we see the wasting of the body, especially in the muscles.
Rehabilitation program can be home-based or outpatient-based. It involves strengthening the arm and leg muscle as well as the diaphragm. There are few components to this program, and they can include all or few depending on the person's overall physical and mental state. Exercise training. This improves a person's endurance and muscle strength so they are better able to carry out daily activities. Nutrition counseling. This assesses the person's body weight to implement a therapy regime. This is important because if you're overweight, fat around your muscle can push up against your diaphragm, giving the lungs less room to expand during breathing. One of the consequences of COPD is muscle wasting. So if you're underweight, you can lose muscle mass, which can weaken the diaphragm, making breathing difficult. Education on your lung disease or condition and how to manage it is another component. This includes how to avoid situations that worsen symptoms. An example, lung irritants such as cigarette smoke or air pollution. Part of the education is to making sure that you know when and how to take your medications. Another strategy taught is energy conserving techniques. This finds easier ways to do daily tasks without causing symptoms like shortness of breath. It gives tips on how to conserve your energy and breathe easier by avoiding reaching, lifting, and bending. Another component is breathing strategies. This shows how to take longer, deeper, less frequent breaths. One example is pursed lip breathing exercise. It decreases how often you take breaths and keeps your airway open longer. This allows more airflow to flow in and out of your lungs so you can be more physically active. The last component is psychological counseling and group support. People with chronic lung disease are more prone to depression, anxiety, and other emotional problems. This program helps to cope with this. The resulting effect is an overall positive effect that helps patients cope with moderate exercise and carry on their daily routine. Beneficial effects on dyspnea, improvement in muscle strength and endurance, and psychological status is seen. There is reduction of hospital admission and improvement of health-related quality of life with increase in daily physical activity.
The title of the study chosen is Home-Based Pulmonary Rehabilitation for Subjects with COPD, a randomized study. The effectiveness of the rehab was measured by using the 6-minute walk test, St. George Respiratory Questionnaire, treadmill endurance test, and spirometry. The hypothesis of the experiment was that COPD patients using a home-based pulmonary rehabilitation program will achieve greater physical capacity than patients without the training exercises. Initially, there were a total of 50 participants with COPD included in the study. However, only 44 remained until the very end. Incomplete participation in the study was due to death, failure to provide consent, or exacerbation. Participants included are diagnosed with COPD between the ages 40 to 75 and provided their consent. Those who were excluded have already participated in a similar rehab program or have been involved in a regular physical activity within the last 12 months. And those with another present disease, which may result in exercise intolerance, were also excluded. Those in the randomized group would participate in the program that consisted of 4 steps, including the warm-up, aerobic activity, and then stretching and relaxation. Aerobic activity was divided in 3 stages. Stage 1 was introduced in the first week, where the participant would walk down a hall or corridor for 40 minutes. Stage 2 was introduced in the second week, where the participant would do stair climbing or use a platform if stairs were not available for 15 minutes. Stage 3 was also implemented in the week 2, with the oil can in addition to stairs for upper limb exercises. Both groups were followed up on every week. However, the randomized group would be receiving motivation, whereas the control group was not given any further instructions in terms of exercise. Overall, the randomized group showed to have improvements in exercise capacity and quality of life, whereas the control group showed no difference in any of the variables above. One of the good things about this study is that it uses the RCT method, which is the best way to assess the effectiveness of the program. RCTs are typically used to evaluate cause and effect, and as they are the gold standard when it comes to ascertaining the efficacy and safety of a treatment or intervention. They have low risk of systematic error and provide the highest level of evidence, making the study highly reliable. Another pro to this study is that it proves that there is a positive effect of home-based pulmonary rehabilitation, making its findings significant and appealing to those looking for a more inexpensive and accessible form of rehab for COPD. One thing missing from this study was that the effectiveness of the program on a long-term duration was not measured. Future studies need to be done to analyze a long-term duration of the program. In the article, they state that there was no follow-up with the participants after the program to evaluate its long-term effects and were instead advised to continue to exercise on their own benefit. So although this study proves that home-based pulmonary rehabilitation show improvements, it is unknown as to how long it would last, making the effectiveness of the home-based pulmonary rehabilitation still questionable. So these are our reference used. Thanks for watching.